Okay, everyone, we are here for the Return to Run postpartum series, and I'm super excited to have our guests today. We have Sara Tanza from Pelvic Potential, and we have Jessica Dorrington. She is from, pronounce the company name.
Therapeutic Associates.
I think I see the Instagram, IG, and then I want to say something different. So.
Yep. No worries.
And Aubrey will be here. She's moderating and checking the questions. And if you're listening and you have questions along the way, or you have questions right now off the top of your head that you would love for us to get to, we will try our best. We do have some questions that other people have sent in that I want to get to today, but we're going to start with basic return to run protocol and discuss how we work with clients and patients. And I first want to introduce or let Sara and Jessica do a quick intro of themselves. So let's start with Sara. Why don't you go ahead and do a little intro, your background and how you got to where you're at now.
Hi, everyone. Thank you so much for having me today. I respect everybody that's up here today speaking, and I'm so excited to hear all your questions. So my name is Sara Tanza. I have a doctor of physical therapy. My practice is located in Santa Cruz, California. And I got to the world of pelvic floor physical therapy first out of PT school from UCSF SFSU, working actually at, I did a residency with patients that had spinal cord injuries and strokes and other neurological insults. And I was there to learn a specific technique that I was going to hope to apply to orthopedic patients down the road. I ended up staying and working with that population for almost 5 years. And so started with neuro patients. Then I went to working with patients that had like more basic musculoskeletal injuries. My knee hurts, my shoulder hurts, I want to run faster, those kinds of things, right? But I really was missing that like return to like a really good quality of life, the things that I helped my patients with when they were learning how to be more independent after having a spinal cord injury, for example. And that's how I kind of fell into pelvic health, between that and obviously having kids myself too, and seeing how underserved this population was. Over the years, I've been able to blend my orthopedic background and manual therapy background and all the neuromuscular reeducation things that I did with my neuro patients with this really deep passion for pelvic health. And so that's where I like to hang out. And as a big runner myself and a big running nerd, that's been a really big passion of mine, is getting people back to run safely postpartum. So excited to talk to you today.
Awesome. And I love your unique perspective of learning the neuro first. And obviously the running background. I know you were a triathlete in college, and you've worked with, I know, Steph Bruce, and there's a lot of others that you've helped at a high level, and recreational athletes as well. So super excited to have you. Jessica, how about you? Quick intro.
I started off 19 years ago as a orthopedic physical therapist. And I think anybody in college would have said I was the last person to do pelvic. And my first job was like, we need somebody to do pelvic floor. And so my career kind of began with doing both of those in tandem, really wanting to dabble in the sports world and really help people get to the most efficient, whatever that is in their sport, whether that's walking or kind of the pro and Olympic athletes. But then on top of that, really went down the road of getting manual therapy certifications, my board certification, orthopedics. And so just melding those two worlds. And so I run a practice here in Portland, Oregon for Therapeutic Associates, Bethany, and get the honor to work with a whole host of both peri, postpartum moms, but also then have a pretty unique situation where I can work with a lot of Olympic and pro athletes as well. So all of it really focusing on the core and just how this core and system really work to give us our power and give us a good basis to do whatever we want to do together.
Awesome. And you have quite an elaborate background too. So I love both the perspectives that we're going to get to hear on how you kind of tailor pre and postnatal return to run, I should say postpartum return to run. So the first questions I have for you guys, and maybe we'll start with Jessica. When someone is recently postpartum, what do you recommend? Maybe you can list like 3 or 4 or just your top things. What do you recommend women do before they try to run postpartum?
Number one, as a mom of 2 kids, enjoy your time with your baby. I think we are so fast to wanting to get back. Runners, we love to run and we want to get back as soon as we can. But I think just number one, realizing that those are really special moments and we're going to have a long time to be able to get our system and get back into our running goals and those types of things. So number one, it would be just enjoy your baby. The second thing is just setting yourself up for success, realizing that the postpartum period right after baby is really about replenishing your energy stores. And so the more we can sleep, the more we can nap, the more we can kind of fuel the systems, because the system has had a ton of energy expenditure through the delivery phase. So I think replenishing is probably the second. And then the third would be just setting your body up for success. You know, our foot structure can change almost up to a half a size in shoe wear. So making sure you go get a new pair of shoes or make sure that your old ones still fit appropriately. And then supporting, you know, the chest and the ever growing changes that happen in the chest, and making sure that you have a really good sports bra that doesn't allow, if you stand there and look in a mirror, you shouldn't see any bouncing of your breast tissue. And if you do, going and getting a professional fit and maybe a little bit more stability through that system.
Those are great suggestions and awesome things for women to think about early postpartum.
And you get excited. You get to go to the running store and, you know, like get a pair of shoes, or at least look online.
Yeah, for sure. Sara, how about you? What would you say are things you encourage them to do before they try running?
Yeah, everything Jess said was great. So listen to all those tips for sure. I think that in the early postpartum period, I think that rest early on is one of the most important things people can do, kind of, you know, like what Jess was saying, if they can. And I'm talking about professional athletes. I'm talking about amateur athletes. I'm talking about no one is athletic at all. As much as you can be laying horizontal for the first like 2 weeks, that would be amazing. I think that's the best thing you can do to set yourself up for a return to run. If you had a C-section and you get upright, that's like a lot of gravity going on to a healing incision. If you had a vaginal tear, or even if you had a vaginal birth with 0 tearing, your pelvic floor stretched out a ton. And so it's kind of like the equivalent of when you roll your ankle and you have that really loosey-goosey ankle for a while. That's the equivalent of what your pelvic floor underwent, right? And so every time you get up, you're putting weight on that. And so if you were to have like a surgery on like your biceps tendon, for example, you're not going to put a big weight in your hand, right? And so that's the equivalent of weighting the pelvic floor or weighting that healing C-section scar. So first thing first, try to rest as much as possible, as being as horizontal as possible for the first 2 to 3 weeks. And then gradually building yourself upright the same way you're going to build up your running mileage. And so it's kind of crazy because even if you were running or walking up until the day you gave birth, right? We all kind of start together from a level playing field, no matter what level you're at. And so building back in even just more time on your feet, right? Rather than even just like walking right away. That first walk you're taking postpartum, making your sights like very, very low. I always say like walk to the mailbox and back, walk to the first stop sign, then to the second stop sign, maybe walk a little bit in one direction from the front of your house, loop back, and then walk out the other way, because we've all been at that point where we've gotten out too far, right? And then it's like, oh crap, I got to call someone for a ride, because you can really, you know, your symptoms can go from nothing to getting pretty bad right away. So that's the early postpartum period. Rest, eat all the good food, and then start your walking very slowly. Then as the weeks go on, I recommend my patients or anybody who's returning to run really builds a strong walking base first, because we know running is like 2.5 times the ground reaction forces of walking. And so I like all my clients to get up to being able to walk like minimum an hour, up to an hour and a half for their long walk before they even think about running at all, right? And so their body is used to that pounding, okay? And then going through, we'll probably talk about later, some type of a return to run screen with a physical therapist. We all, you know, work virtually, and a lot of physical therapists do now, or in person, hopefully. I know in my Instagram, my link tree, I have a couple little things under a return to run blog, and I know that Jessica and Celeste have some resources as well. So checking all those things out, and we'll go more into this as the day goes on.
Great. I love those. I would add, like, after the rest, I think sometimes I think of the more, obviously the more training side of things, right? So after the rest, what type of exercise steps would I take? So with you, for sure, walking first, and then the core pelvic floor reconditioning. And so I think it's definitely in the last 5 years more so been like, oh, this is just something we should just do, right? Like, not because we want to go run, or, you know, it used to be like, well, yeah, I can go run and maybe work on my core if I need to, if I have ab separation, but if I don't, then, you know, it's fine. But I do recommend everyone does core pelvic floor reconditioning first, along with the walking, and then progresses into, you know, very basic broken down running drills. And then, you know, the hill walking can be a great way to start introducing the more load on the pelvic floor, but not as much as running. So the uphill walking and then uphill running, downhill walking, you know, breaking it up that way is a great way to introduce the body, the pelvic floor to impact and get it used to all the coordination that it has to be doing without fatiguing, right? Yeah, do you guys have anything you want to add to that before we move on to the next question?
Yeah, I think just, I love, Sarah, what you said about the out and back. I've seen so many moms that, whether it's walking or the very initial phases when they do start running, you know, decide to go do their old favorite loop. And so the out and back, whether that be there or on the hills, I think is so important, because you can do several of those and kind of build up your endurance. And on the pelvic floor component, you know, the pelvic floor is so important, and we can start that as soon as the pelvic floor is ready, right after postpartum. But knowing that it's not just strengthening of the pelvic floor, that it's also the coordination. No different than the running drills you're talking about. Our body needs to learn how to remember how to do that neuromuscular control, or those movement patterns. And so the pelvic floor, learning several different types of pelvic floor contractions is helpful.
We do have a question from the chat about this like early postpartum period. So they ask, what should we expect from an in-person visit with a pelvic floor PT?
I can answer that. If it's, you know, it depends on when it is. So pelvic floor PTs are also orthotherapists. We take a look at you from a full body and say, let's look at your hip strength. Let's look at your core strength. So we're going to take a look at all the orthopedic pieces and say, you know what, we need to get your hips stronger. We need to get XYZ stronger to prepare you to run. And if you are before the 6-week kind of standard period, 6 to 8, depending on the physician, you know, we are looking at how your pelvic floor muscles look externally. We also can do internal pelvic floor exams, and that is done once you're cleared for intercourse. And that's case by case basis on who's coming in and if that's appropriate. In our clinic, we also use ultrasound imaging, which is really fun. We get to see your core muscles. We get to look at the diastasis or diastasis, depending on what you want to call it, and really teach you how to get your core muscles and how to coordinate them.
Sarah,
I'll also add too, yeah, I was going to say that also pelvic floor physical therapy is something that you can do before you get pregnant. You don't have to even have been someone who wants to get pregnant, right? You have ever done pelvic floor. And I know I can speak for Jessica too. We like seeing people before you get pregnant. We like seeing you while you're pregnant, and we like seeing you postpartum, right? And it's really nice because a lot of times then if you're pregnant, for example, you can learn some of the coordination that Jessica was talking about, some of these drills, some of these like things, even that now you're postpartum, you're 6 weeks, you have a crying baby, you're tired, you don't have to then learn in that sleep deprived state. It's never too late. Please, you know, come no matter what, but it's kind of a fun thing if you can practice some of these things during pregnancy. And for people who might say like, ooh, internal pelvic floor physical therapy, what's that about, right? It's actually kind of cool. I mean, I always think about like what's going on the pelvic floor is kind of like I'm getting dressed in the dark. And did I put on a purple shirt today or did I put on a yellow shirt? I don't really know, right? And it's not like we can be in the mirror saying like, that's what my arm is doing. And so a lot of times when we can get in, and obviously we use gloves, we use lubricant, and we use lots of education and lots of consent with every single step of the process to make people feel really comfortable. But we do intervaginal and interrectal work depending on what's indicated, the same way we would work on your shoulder, right? And we would say, oh, okay, what muscles here are tight? I'm going to feel this muscle. I'm going to feel that one. I'm going to feel your scar. Ooh, let's work on that scar for a little bit. Okay, now let's see what's a little bit weak, what's a little bit tight. Let's get those ones that are kind of out of the loop to get back on board again. So we think about the pelvic floor like any other part of the body, right? And by doing that internal work, we can just kind of get to those muscles directly. And I just tell my patients, we can definitely do things external or not even with, clothes off at all. That's definitely possible. With virtual work, we can have patients touch their own pelvic floor muscles and get some really good information as well. But it's kind of like a really nice way to just figure out what's going on as fast as possible.
And Sara, you hit that so perfectly when you said pre and peri. There's so much research that says we are twice as likely to get back to the activities we love to do. We're twice as likely to get back our abdominal tone after baby if we've done the work during our pregnancy. So not that it's too late to come in afterwards, but it makes it so much easier if we've been able to have that time. If at 12 weeks pregnant, if someone is coming in and we can really get started on the core work, the pelvic floor work, teaching them how to push appropriately, and so that we can prevent some of the pelvic floor lacerations, that is absolutely just sets us up for success postpartum. So knowing that holds a big importance.
Great. Yeah, so let's go to the next one. So I think this is a big hot topic, time frame for returning to run. Do you have an earliest time frame you would allow someone to return to run? Does it determine case by case? How do you approach the return to run guidelines for your patients? Sara, start with you.
Yeah, this is a hot topic, right? Because we've kind of swung in both directions, and it really is a case-by-case basis. I think that getting cleared at 6 weeks by your OB should never be the time when you for sure should say, I'm ready to run now, right? I think that there's a lot more that goes into it. It is going to be dependent on the kind of birth you had. And I'm not just talking vaginal versus C-section, right? It's like people have vaginal births with mellow recoveries and C-sections with horrible recoveries, or C-sections with great recoveries, right? And so what I look at individually for my patients is that no matter what, they either have a healing C-section incision, or at best case, a vaginal, area, and those pelvic floor muscles that, like I told you before, have done this major stretch and are now kind of like a loose ankle that you got a really bad, rolled ankle sprain too, right? And so I just look at risk versus reward. And even with my most high level athletes on the biggest stages with the biggest risk versus reward where they need to return to something fast, I still don't think that that running really early at 6 weeks is the best thing that you can do. I think that the earliest that I've ever really cleared someone and said, it's fine to go and start to run. And let's even talk about what that even means, right? Is maybe, 6 weeks possibly, but really it's like 8 weeks. And I think more so the 10, the 12, the 14 weeks, I think is great. But what does return to run mean? In my case with my patients, it's the time when they're first starting to do like a walk run interval, right? And so it's not like, oh, I'm going to go run 4 miles today, right? It's going to be, I'm going to go and run for a minute and then I'm going to walk for 3 minutes, right? I'm going to go run for 30 seconds, right? That's when I'm probably starting to incorporate that. But before that, we've done so much, and we'll talk about this later probably, but they've increased their aerobic base by doing a lot of other things, right? They've done a ton of walking. They've done a ton of cross training. Maybe they're even doing tempo on cross training, right? And getting some of their aerobic fitness back. They're doing a ton of musculoskeletal training and strength training as well. And so I think if you think about in the pelvic floor, what we're worried about, the big things that I'm concerned about are worsening a pelvic organ prolapse. And that's when the pelvic organs descend into the walls of the vagina or into the rectum and the anus itself. I'm looking at any type of a crazy joint laxity that could set someone up for pain, like in their pubic area, in their SI joint, or any type of like musculoskeletal injuries that are coming on because the whole core system has gotten so weak that they're more susceptible to these other injuries. We know, for example, femoral stress fractures, the risk goes way up with pelvic floor dysfunction. So also if there's pelvic floor dysfunction as well. And I also believe that every patient who's breastfeeding and somewhat athletic is probably in some degree of red S. And so bone health is super important in that stage too. So short answer, it depends.
Yeah, lots to consider. How about you, Jessica?
Yeah, that's a one with a big asterisk on it, is so patient dependent. And not only is it patient dependent just on the time frame of, 12 weeks is pretty much the standard of when I say, okay, this is when you should be ready. If we see that your strength is there, if we see that your energy expenditure is there, but that could change at any given moment. And watching with your patients, I think that's where having a pelvic floor PT to help walk alongside that return to run progression, or any, trainer or anybody who's trained in kind of this postpartum phase. You may all of a sudden have a baby that's not sleeping for 2, 3, 4 weeks. I'm going to pull you back because I know if that energy system gets too low, our risk of stress fracture skyrockets. And so now we're back to taking that back. We can't just say at 12 weeks, you're ready to go. We really have to go based on kind of what's happening each week for them, and teaching them the knowledge pieces of saying, okay, this week I realize I only slept 3 hours. I know that sleep 7 to 9 hours a night. If it's less than that, increases my risk of the stress fractures that Sarah's talking about. So I'm going to have to choose to take a nap instead of going back to my run program, which I thought was there. And I think from a pelvic floor PT's perspective as well, Sarah said it depends on so many of these variables, but it's how are they transferring the load across their core or across their diastasis or diastasis? Is it ready for them to go back, or are we just going to now reproduce poor movement patterns and inefficient strategies? Would they be better served on learning that strategy, really getting that strategy down, and then moving it in? And on the flip side of that, I've had some moms that are, in terms of like, you think about postpartum depression, and that is their friendship circle. That's where they get their connection from. And if they need to go back and they're having a few of these check mark boxes that PT, we say you're not ready yet, but I see that it's going to help their overall mental health, then there might be a change in when I'm going to let them go back as well from those components. And then from the pelvic floor, there is a way for us. We know that 47% of women are pelvic floor changes, kind of the bowl of muscles that kind of support the vaginal opening. And so there's ways for us to see if that prolapse is happening. There's ways for us to actually measure and say, oh, that opening is at a point where we would like to get a little bit more pelvic floor strength before we have you go run to prevent the prolapse. So really just working with someone who can help dial in all those pieces and then say, yes, you're okay to return to run.
That's great. And I do see, you want to add something?
I was just going to say, first of all, what Jessica said, I can't say enough, the whole person, very important. Mm-hmm. So thank you for adding that. For the person at home, maybe they don't have access to pelvic floor physio or some of this knowledge. The return to run guidelines that we all like that were recently published is a really great place to start. If you just type in return to run guidelines by some of our colleagues, they did a great job and have, some criteria, and they recommend 12 weeks, but have some things that you can look at as well if you don't have someone in your area to see. Yeah, that's a great starting point.
And you can also Google RED. So it's RED-S. So it stands for Relative Energy Deficiency in Sport. And there's actually a checklist that tells you if you're green, yellow, or red. So it helps you to kind of understand if you're starting to go into this yellow zone where you may be at risk for stress fractures, because most women don't get their period back or their menstrual cycle back. And that's a way for us to know as we start to increase the volume and load, even as you start to progress further when we're running in our progression. If you don't have your period as one of those factors, having that RED-S checklist can be really important to know if you are starting to tax the system too much.
I just really hope this becomes standard care one day. Women are just automatically sent to you, ladies. I just don't understand why they're not. It's still like boggles my mind. That being said, I do see some women that, maybe it's their first pregnancy. It was very easy, non-complicated. They go through core pelvic floor reconditioning, and they do fine, maybe 6 to 8 weeks, as long as it's very, very gradual and there's no red flags that show up. Obviously, if red flags show up, they need to take a step back. And so there are some that do fine, but it is the minority. I would say very much so. And, it might be like what types of clients we all see. But I know it, to me, I would love a poll, but I do feel like it's like, I don't know, it seems like it's maybe 10 to 15% of women who try to go run and feel fine.
I don't know, because we don't see them in the clinic, right?
Right. We don't see everybody. Yeah.
Oh, I was gonna say, but to speak on that, Celeste, I think that's such an important factor because we don't see them in the clinic. But what we do see is the women who are now peri and postmenopausal, who have been fine. And they're like, I've never had any leakage. I've never had any issues. And now I'm hitting menopause and now I'm leaking and have stress incontinence. And, that there's people or individuals who are over 65 years old, 50% have leakage. We also know that 50% of women or 47% of women have pelvic floor changes when they're pregnant. So you wonder if, and that's a clinical comparison, but you wonder if we were able to see them when they're healthy,
yes,
would we be able to impact it for the long term, which has all kinds of cardiovascular and other health related factors, so that people will continue to work out and do the things that they need to do if they're leaking later in life.
And then also it's kind of anecdotal, but I'm sure Jessica and Celeste see this too, that sometimes people are okay early on and they ease into things fast, but then they hit like somewhere between that 6 to 8 month postpartum mark and things kind of catch up with them. Right. And maybe it's that whole thing of like, you're getting your aerobic fitness back, you're fine, but then maybe the muscles and tendons haven't, caught up yet. Or it's that you've been doing this whole being a parent and not sleeping well for 6 months, right? And so people develop musculoskeletal issues later on when they didn't have pelvic floor stuff, but then we come to see that actually their pelvic floor has some dysfunction as well, or they even don't develop that pelvic floor dysfunction until months, years after their birth. But really that's where it kind of showed up. So that's why I really love if everybody can have the access, and of course, accessibility is an issue that all of us are working on changing to that, just at least to have a checkup, at that 6 week mark. If you can do one 6 months later, if you can do one at a year postpartum even, right? Just to set yourself up for success.
Yeah. Let's just start from the basis and get that foundation built no matter what. And it just makes sense. Why would we want to wait until there's a problem, right? That's what we're here for, is to help prevent issues. So for someone who does, maybe they just go out and run, maybe they didn't really do any prep work, strengthening work. What are the risks of running without doing any exercise, core pelvic floor reconditioning ahead of time?
I can answer that first. I think the number one thing is just inefficient strategies of how you transfer load, right? And so if you haven't prepared those muscles, if those muscles aren't working maybe in the best optimal way, you're just not transferring load. And what that could mean is it's harder to do. If you're a professional or Olympic athlete, that means now we might be losing some of our power and force that we want to create and generate speed. So I think there's some of those implications. I think the other component of that is you're setting yourself up, in my mind, for other musculoskeletal injuries. So we know if you go out, let's say you don't have good core strategies, you're running and you tend to do too much kind of frontal load lean, or your body is moving in this direction too much. That core stability loss can increase our chance of sacral stress fractures, the femoral stress fractures that Sara was talking about, our tendons like our Achilles. If you don't have enough calf strength, now you're getting inefficient strategies on your Achilles. So it can show up in different ways, even if it doesn't show up in pelvic floor dysfunction.
Yeah, and then from a pelvic floor perspective, I mentioned it before, but Pelvic organ prolapse is one of the big ones that we see. And that's just typically felt as like heaviness feelings in the vagina or the anus, like something's falling out, like a tampon's falling out, right? Urinary leakage, fecal incontinence, all that fun stuff, right? And then, risk of stress fractures and, like Jessica said, all the other, soft tissue and bone injuries.
And from your experience, do you notice if maybe we don't know this yet, but we read a little bit of research lately on it, but does the prolapse, or is it already there and then they just start to feel it because they are doing impact, or do they do impact and then cause prolapse?
Both. Yeah. And we see it like we see it where like it's just from birth. Someone had it. Some people can develop it during pregnancy. Some people have prolapse that haven't been pregnant or before pregnancy. If someone can have it, they cannot have it at all after birth, and they can do too much too soon, and they can develop that. So really all the above.
And on that, Celeste, prolapse, it really is based on our parity. So the amount of pregnancies you have had, I think it increases to like 8-fold after just 2 births. So knowing that the more births that we have, the more that the rugae, we call it, or kind of the stretchy part of the vagina, it just doesn't, my friend, she's an OB, she describes it like a sock. She said, sometimes a sock, you once you've worn it, it just doesn't quite go back to that same when it comes out of the dryer. That's her analogy. But so that allows those organs to just drop a little bit more. So the amount of pregnancies that we're having also influences that.
But you're right, though, that sometimes, prolapse, like someone's actual grade, because we grade like the severity of prolapse, doesn't change at all, but they don't feel it anymore, right? And so a lot of times, like if you're breastfeeding, for example, you're in a lower estrogen state, so your vaginal tissues are a lot drier. And when you're drier, it's almost like you feel tackiness a lot down there. And so that could be one thing. Or the musculoskeletal support is increased, so they feel better. We're seeing there's one theory of prolapse called the biotensegrity model, that some of it might be caused by too much tightness in the back half of the pelvic floor, almost like pulling the front half more open and those organs down. So as that can get kind of like released in the back, so it can change. And the great thing though is that even though we know it can increase, a lot of times it either will stay the same or just get slightly better. Or like we said before, you don't have to make it get better or make the grade go down to not have symptoms from it.
And Sarah, I feel like this is going to be a pelvic floor PT ad, but that prolapse change, as Sarah said, doesn't have to change, but we do know that doing, pelvic floor PT, and if you don't have access, doing different types of Kegel exercises, we can improve prolapse symptoms by 85%. So that's a huge amount to just say, learning some exercises, learning some strategies to kind of help that prolapse can be helpful.
And it's pretty crazy. It's actually in the past week now, like maybe because I'm just checking it a lot more, but 3 different people now in the last week who Jessica and I almost ask people standing sometimes too, and see what that looks like. They had more prolapse, in certain standing positions than in others, right? More when they stood on one foot than the other. By doing more of a good program on hip strengthening, for example, and getting more stability on one leg, they were able to improve their prolapse symptoms. And so prolapse isn't just about the pelvic floor, but it's also about the rest of the hip and the leg. And if I don't have enough power and to absorb the forces, right, they're going to get transferred to the pelvic floor. And so that's why we really are working on not just just this area, right? But the whole body. And if we can get more, soldiers fighting in the army, it's not just like the poor little pelvic floor getting knocked every time you take a step. So really prolapse is more than just pelvic floor muscle strength, as well as pelvic floor muscle strength. It all goes together.
And I'm going to digress on that even further away from return to running, but constipation is another huge component of that, and if you've had an epidural and just the hormonal changes, sometimes we can see constipation being a huge component both during pregnancy and sometimes after. And so if constipation is something that you're leaning towards, really resolving the constipation piece can be really helpful in effectively managing the prolapse so you don't feel the symptoms when you're running.
More so sometimes than any other things you can do.
Yeah.
And even sleep. I think that anecdotally, we've all seen that is when patients are in that state of not getting a lot of sleep, or now with all the heart rate variability monitoring people are getting, if they can look at that data, sometimes it can correlate a day when their sleep isn't as good, they're more stressed, that can go up as well. And obviously changes during the menstrual cycle.
Great info. Go ahead.
Oh, well, I was going to say we received quite a few questions about prolapse, so this might be a good time to bring those in. So someone asked about the time frame for getting back into running. They just developed prolapse at 2 weeks postpartum. And then also someone asked about like functional tips for running with prolapse. So whoever would like to, speak to those.
Go for it, Sarah.
Okay. So let's first start with, I'll start with the functional tips while running. I think that one thing that I see with a lot of people when they're running postpartum is that they're still thinking that they're pregnant, and they're still, doing the waddle and the pregnancy lean and this kind of a thing. And I'll have them kind of like, run like that in place, and then have them try to be a little bit more stacked up and stacking, the rib cage over their pelvis, over their feet, and seeing if running in place, if that can even decrease their symptoms, something as simple like that, right? So Celeste was talking about running up a hill, it kind of naturally lets you get in that position. I also see when patients are running and they're gripping their abs a lot, if you think that you're gripping your abs, you're putting a lot of pressure down on your pelvic floor. And so that can be something else, getting back into running to not do that, right? For someone who's 2 weeks postpartum and is having symptoms right now, first of all, you're 2 weeks postpartum, you have symptoms right now, I would definitely try to schedule an appointment with a pelvic floor physical therapist, either in person or virtually. I would put yourself mentally on that slower track for return to run. Think of what that 12 weeks postpartum is, look it on the calendar and say, I'm not going to probably run before that point, get that idea out of your head. And then first start to work on some of the other hip strengthening, pelvic floor strengthening, and increasing your walking to the amount that you can walk without having symptoms, and do other cardiovascular exercise without having symptoms, and increasing that really slow. I forgot the first question, so maybe Jess can take the second question, or that
you got both the functional tips.
I think you got both. Yeah.
And prolapse.
And I'll just add on to that for functional tips, prolapse gravity takes place. And so when you're going out and returning to running, trying to go out and run in the morning when your pelvic floor hasn't had to kind of posturally support you throughout the day already, where those pelvic floor muscles might be getting a little bit more fatigued, I think that can be really helpful. Depending on if the prolapse is more the bladder, the uterus, or the rectum, right? It could be in the front or the back. But if it's more the bladder, going and maybe starting some of, like Celeste said, those uphill runs where you are going to lean into kind of the forward motion, or running on a treadmill with a 1%, 2% grade, sometimes that can put less pressure on the pelvic floor and make you feel more comfortable, or walking down hills if that feels like you're going into the position where Sarah is talking about. So those are little tips and tricks. And then in terms of the 2 week, we obviously know waiting until the 12 week, but then it's really figuring out what your pelvic floor strength is. And, for people who don't have access, if you do a Kegel contraction, which is kind of closing the rectum and seeing if those muscles, you could feel them close the openings, but they should also lift up towards your nose. They should be able to do that kind of Kegel contraction. They should be able to feel that lift. If they have the lift and they're still having the prolapse symptoms, or they go see a pelvic floor PT and they say, hey, you're strong in your pelvic floor, but you're still feeling symptoms, then there are things that they can do in terms of inserting something called a pessary, which can help kind of hold up the prolapse symptoms to get you symptom free, and going out and doing, I always think it's just like helping take a little bit of load off Atlas as he's holding everything up, just to take some of the pressure off the pelvic floor.
Great. So the one thing that popped into my head, which is one of the next ones on here, if someone has leaking while they're running, what do you recommend? Do you ever say it's okay if it's minor, if it's occasional? Are you telling them to stop? What would you recommend? Yeah, Jessica?
Yeah, I think that's a big asterisk again, because one, the mental health, but two, what else is going on? And I'd want to know what the leakage is from. You know, is it there's leakage when we're running, if it's urge incontinence, where someone might be, every time they were pregnant, they ran by the same toilet at the park, and that triggered them going, oh, I have to urinate. And now they're postpartum and they're running. They get the urge when they're going next to that and they leak. I'd be okay for them to be able to run through that. If it's more based on stress incontinence, then I would say your system isn't transferring the load. And, you know, I think there's not a huge, great support in our research yet in terms of what we would do from a clinical perspective. I would say it's not transferring the load. Could we do other things first and then get you symptom free and get you back? If running is really that important, and it's a few drops of leakage the first minute or two, then I'm okay with them continuing.
Okay, Sarah?
Yeah, I mean, I would probably echo everything that Jessica said. Other things to add is, yeah, identifying like when is it occurring, and maybe even if it's something like, is it time-based? Is it mileage-based? Is it the time you run? Is it the place you're at your menstrual cycle? Is it always a day where you did, like I said before, didn't get enough sleep the night before? I really do think that's something that we're going to see a lot more of in the research as being a really big predictor of even things like urinary leakage. But again, it depends. And I think that like, if we can, in the moment when people start to feel leakage occurring, or they feel like that it's about to happen kind of feeling, that can be a really nice time for them to experiment with themselves, right? So thinking about different things in their running form, thinking about like even shortening their stride. If someone is like, you know, overstriding and their foot's landing way in front of their body, think of that impact that's going into the whole system. So maybe in that time, they can increase their cadence a little bit, really think of their foot landing underneath their body. They can think about like relaxing their abdomen, changing the position of like maybe their pelvis and their ribcage. And there isn't the right answer. It's going to be person dependent. And so even just trying to make some of those little changes to your body and seeing if any of those things can help. And that can be really magical, right? Because then you can say, hey, that's something I could probably be doing more often. Also, people experimenting sometimes with doing either pelvic floor or hip activation exercises before they go out and run. That can be something that can work really well too. But I would say mentally, it's the most important thing. If it's someone who's literally soaking through their shorts on every single run, that might be a time when we would want to pull that back a tiny bit. I would say that that's something where I may be worried about them having more long-term damage, especially if it's in the first like 16 weeks postpartum, when we know stuff might not be all the way healed yet. So that early postpartum period, I'm a lot less tolerant with having leakage, especially if it's like a big amount.
Okay.
And one last thing on that is just, you know, knowing that Kegel just strength is not always what we're looking for. It's really about, can the pelvic floor coordinate? So doing exercises where you're doing fast kind of quick flick contractions where you can squeeze and relax, doing a pelvic floor contraction where you do a halfway hold with a couple quicks, or an elevator where you're going up a couple 25%, 50%, 75%, 100, and then being able to control it on the way down. I see so many women that are leaking, they can't control the kind of slow descent of the pelvic floor. And so, you know, knowing that that leakage doesn't necessarily have to be a strength issue, it might just be the coordination of the pelvic floor itself.
Yeah. Didn't you post something like that, Celeste, online? I thought it was you, maybe it wasn't, but it was like just some like really good graphic of just kind of like what Jessica was saying, some of these just like little fun activities to do.
Yeah, I don't know if I did the graph, but yeah, I do mention about coordination a lot, because you do see it where they have great strength, and maybe the body's just not used to the impact quite yet, or it's just too much time on their feet. The pelvic floor is not able to coordinate that long quite yet. I feel like I have things pop into my head and then I lose it really quick, but
I will say, while you're gathering your thoughts on that too, and then what Jessica was with coordination was also referring to too, is like, can you even let it go, right? So many of our patients we see perinatally, everyone thinks they're all loose in their pelvic floor, but the majority of them are walking around in that semi-tight state whether they had a C-section or a vaginal birth. And even though maybe their vaginal opening area is larger than it was before and they feel really open, their muscles are still really tight, right? And sometimes, like I mentioned before, if they have a lot of tightness, let's say around their anal opening area, that might also be creating a pull and opening up the front a little bit more. And so that patient that feels really heavy and open in the front, but they're also complaining about hemorrhoids or anal fissures and constipation, things that maybe make us think that they have tightness towards the back half. Some of those patients can also benefit by doing relaxation work or even telling themselves to relax the back half, like the anal part of their pelvic floor when they're running as well.
Great. That's great. Yeah, so much to go over. The next big question, and this goes right along with what we've been talking about. Someone asked, are there specific muscle groups besides the pelvic floor that you should focus on strengthening postpartum? So if you guys want to shoot what you target and tackle postpartum, that'd be great.
Yeah, I mean, first of all, is just getting the basis of the core. Transverse abdominis is still one of the most important muscles that we target. Just using that to get some good neural coordination. I think of the muscle as like, it should be able to anticipate movement and just work automatically for us. And postpartum, that muscle sometimes is almost like driving a stick shift car instead of an automatic car, where we have to kind of teach it how to turn on again. So doing a lot of transverse abdominal work with our pelvic floor coordination. And then obviously all the other big muscle groups, doing lunges and squats, really getting a lot of calf strength, because so much of running is the transfer of load through the calf. And so making sure that our calf is really strong, and then progressing into things like single leg hops, single leg squats, where we really can balance and control. And back where you said, Celeste, in the beginning of the running drills, neural coordination is so important for women. It's more important for women than it is for men. And so being able to get the neural coordination of what it feels like to be running. So there's a lot we can be doing in the time frame to make us even stronger runners when we do start to run.
Yes to everything that Jessica said. It makes my life easier. I would add basically anything that's going to control, let's see if I can make this go down a little bit lower, your ability to be strong in this position, right? So can I be in this position on one leg without any crazy hip drop, any crazy pelvic rotation? You know what I mean? And then how can I be in this position, right? So those are kind of the two big places, and obviously moving between those. But if you're in like that single leg, almost like lunge or split squat position, and you can't control it, you're having everything kind of go wonky, you're fatiguing, you can't fire your glutes. Those are the two places that I really, really like to look beyond everything else that Jess mentioned and pelvic floor strength itself. And so if your body is doing something funky in one of those positions compared to the other leg, that's a really nice place to start. And you can, because that's two of the things you have to do when you run, no matter what. And so I'm looking a lot at like the muscles that keep us, being stable without kind of having that hip go out to the side. So some of the hip abductor muscles, the hip rotators are super important too, because those are the ones that are preventing that like little knock-kneed type thing that might happen when you do a single leg squat. And we know that especially those hip stabilizers, they can get really stretched out, right? But from either just carrying a baby or from having a vaginal birth, those muscles go through a stretch phase. And again, back to that ankle sprain analogy, right? When muscles have gotten stretched out, there's something called the length tension relationship, that when muscles are longer, when they're more stretched out, they can't fire as efficiently. So that hip stability, that hip strength, our ability to control ourselves when we land on one leg or push off one leg is just diminished a lot when you're pregnant and postpartum. So getting that back is essential. And a lot of times that's really important for preventing some of the pelvic floor issues as well.
That's awesome.
And then hip extensors, like you got to have booty. You don't want to have a mom butt, right? Yeah. And not just for aesthetics, but you can't have a mom butt for running. So that's a big thing, really. And maybe it's someone who they never could find or fire their butt before they were pregnant. That is the number one thing I'm going to make sure they can do before they walk out of the clinic, is find their glutes.
Yeah, for sure. And right along with the muscle length tension relationship, I mean, that's one of the things why the TVA is so crucial because it does stretch out so much, and all of the core muscles stretch out. So we can't ignore all of the core muscles need attention. But I do feel like loading that transverse, not just activating, but loading the transverse progressively is just really key to helping stabilize. I sometimes don't like that word, but just helping get the proper strength back and response back in that transverse muscle. And a lot of times I think that is what can really help with people with ab separation. That strong wall behind the stretched out tissue, it becomes a protector through intra-abdominal pressure. So yeah, all the muscles, all the core muscles, right? Start from the inside, work your way out. I guess that's the approach I take it. You're eventually doing full body, you're doing all the exercises.
Yeah, and remembering
running, single leg type exercises, oblique sling exercises. So yeah.
And remembering that, like, you know, the pelvic floor is the bottom of the core, right? And so, like, can we get that pelvic floor closure? Can we get that pelvic floor lift? Then can we bring on transverse? And so a lot of the patients we all work with, you know, they're really good at firing their upper abs, just getting those guys going. And all that's going to do is be putting pressure down. So what's less is talking about this deep core, getting that pelvic floor and then low ab, you know, I call it like a baby lift. Can they get that to work together? It's just one of the best things to learn pregnant and postpartum.
And Celeste, I love how you talk about the transverse progression as well. One of the other core muscles, but one of the other muscles I think is one of the most underserved is rectus abdominis. You know, we forget about that rectus got stretched out and it had to make space, right? 100% of women get a diastasis or a diastasis of their musculature with pregnancy, and that the rectus abdominis stretches. We need to bring that rectus back so that you can bring this pubic bone up to the belly button and the rib cage back down so that they get some good solid foundation. So we really progress pretty quickly once you can find your TA using those oblique slings, using your rectus abdominis to build that back so you don't have too much of that anterior tilt when you go back to running. And then I think the thoracic rotation is the other component. You know, when we're pregnant, that diaphragm comes up almost 2 inches, and then baby comes out and we still kind of live in this position and we don't get the correct rotation, which is what we need for when we return to running. We need that amount of rotation. And so really doing a lot of thoracic rotation work, I think, is also really important to get our breathing function back as runners, as well as kind of the rotation that we need.
Yep, excellent point. Okay, we are running out of time. Just a couple other questions that people had, I'll try to get to real quick. Someone said, how do you build back mileage and speed? Do you recommend women build endurance first before speed? And I think this is a great question. Sometimes I do see people recommend, maybe not in the running world so much, but maybe other trainers that they're doing like these short sprints to start. And, you know, I'm like, wow, that's quite the load on the system right away. But, you know, tell me what you guys think about your progression of what you do returning to run.
Yeah, I mean, like I said, I really like using other modalities as well as just running to get people to even just get that aerobic fitness back. And so if someone is really into biking or elliptical or whatever, like at Peloton, if they can start getting some of that back that way, I think that's awesome, because then they're not challenging aerobic and musculoskeletal at the same time, right? So I would definitely do that first. And then I don't think that I have a good answer for this. I think that endurance before speed, probably, but then starting out, I think that speed can be really amazing. And that like when you're doing a little bit of sprinting, you run way better and your endurance doesn't fall apart. And so I will say when people are doing endurance work, I really recommend that, like, especially if they're doing like an interval, like they're up to a 3-minute run interval, that 3 minutes of running is really good quality. It's not slogging along. And when they feel their form deteriorating, their cadence deteriorating, they kind of shut it down and say, now that's 2 minutes instead of 3 minutes. And so, you know, starting with something like really simple, like I think uphill running, uphill sprinting is a really good place to start, like Celeste mentioned, because it deloads the pelvic floor. And then doing something really simple, even just like strides, and starting that out with that nice acceleration and deceleration would be a good place to start.
Yeah, I definitely follow the same mind thought as you in terms of like increasing your endurance first and then your speed. When you do start to increase the speed, I think the strides and the hills are the most gentle on kind of our tendons and load. And then I start to think about it, you know, just in terms of running, like the 80-20 rule, right? 80% of our running should be easy. And so I don't want a mom who might only be going out there 3 days a week and doing all high intensity, because then we don't have our 80% that's building our aerobic capacity. So I do like to see more of that aerobic conditioning first and then start adding the intensity afterwards. And I like the 3 days a week because I think as runners, we love to get back into running. And if you start 3 days a week, then you have to do your other homework of strength building and some of the other things before you can get back and kind of build more of the mileage, as well as it gives you that freedom to say, okay, today I didn't have a good energy system. I'm really fatigued. I need to take a nap, as opposed to saying, okay, let's go out and just hit endurance and run 5-6 days a week. Then we're not leaving space to kind of make those changes.
Yeah, that's great. And I would just add, I do like to do the slow, easy running, but I also like to do the running drills. They're just modified, right? So they're less impact, and you're starting in a modified plank position, and then maybe you're doing it against the wall, or you're doing hill runs. And so you are waking up quick muscles, but the impact is a lot less than it would be in a typical, fast run. And as you know, like working with athletes who need to get back to high levels of speed, how much impact that is on the body, it is a lot harder for that pelvic floor in a really fast sprint. And the pelvic floor really does have to be able to coordinate super fast and handle that load really well. So that's definitely the most difficult for the pelvic floor. But like Sara said, you can do fast stuff in modified ways and help them get there.
And then just as the pelvic floor has a lot of load, but you also have a lot of load on tendons that have gone through postural changes for the last 9 months. So really kind of looking at it from an orthopedic lens of saying, how is my Achilles handling with my hill strides? Am I waking up with more Achilles tenderness? And should I change that dosage based on maybe some of the muscular components that I'm feeling? And it's okay for tendons to have load, but we don't want to go past the point where the tendons can't adapt to that load. So just following the guidelines of those.
Yeah, perfect. Do you want to add that one in, Aubrey? Or I think there's one comment at the end.
Yes. Yeah. So we got one more question in the chat. So she asked, in your experience, are athletes, specifically runners, more prone to any specific pelvic or strength problems throughout pregnancy, birth, and postpartum? And she just said quickly, like her backstory is that she's a lifelong athlete. She's had chronically tight hamstrings, hip flexors, and she's had to do a lot of work throughout her pregnancies to stay healthy, injury-free, and get back to competition. So she's wondering if maybe she's more prone to that type of stuff because of her running background, I guess.
There's a huge amount of research that even those athletes who haven't had pregnancy have more incidents of pelvic floor dysfunction, and in the running world and the ball sports, so they tend to be the highest. And that can be up to 80% of athletes have some type of incontinence at high level athletic activities. So yes, there's things that the pelvic floor can almost get overtrained. The other thing we have seen, at least clinically, not necessarily in research yet, but with the amount of high level athletes that we see here on the ultrasound, what we see is they become so oblique dominant, and not that their transverse is weak, but they get so they use their obliques all the time, right? Because they create power, they create our movement patterns. And so we end up having to put our transverse abdominis, kind of those neuromuscular coordination exercises of the core, we have to keep those in their program. We find that if we take them out of their program and then 6 months later we check again, we've kind of got out of balance. So I do think there is something that we as athletes need to kind of just know that the local core needs a little bit different work.
Yeah, and then I would also just add that like all of that hip stuff it's just so important. Like continuing to look, if you know you've had issues like before pregnancy, just continuing to check in with how stable you are on one leg, like during pregnancy, during postpartum, because a lot of times like it can just point out a lot of different things, right? And it can sometimes be like the yellow light before the red light of injury. And so seeing, you know, how you feel standing on one leg compared to the other leg, how you feel squatting on one leg compared to the other leg, you know, putting your finger inside your vagina, guess what? You can do that, right? Seeing, can I feel my pelvic floor muscles close and lift and relax when I want them to? Or do I just feel all my abs come on? Maybe during one of my ab exercises, do I actually feel bulging down in my vagina, right? That's not very good. So we can kind of start to just kind of self-assess and see. But for that person, it'd be really nice for you to get followed if you can by a pelvic floor physio during your pregnancy, if possible, and afterwards, just to ensure, because sometimes it's like you are putting your body through a little bit more stress than the average person. And it's nice to have those extra resources on hand.
That's great. That's great. And in the end, we're just trying to get these muscles to be happy, right? We're getting that length tension relationship happy again, and we're getting them to respond appropriately to load, but also to relax when it can relax. That's really, we're just getting these muscles to respond appropriately again. When you think about it, they've just had a lot of changes, and they need to be able to contract. They need to be able to relax, and that's the goal with all these muscles that stretch and get ignored for a few months. But okay, do you guys have anything else to add? We pretty much went through most of this, and it's 8. I don't want to keep your time. So I had a lot of fun chatting with you guys today, and we had some really, really good topics and tips. So yeah, I'm really thankful you were willing to come do this, and maybe we'll do this another time. That would be so much fun.
Definitely. I can't wait.
Yeah.
And I just thank you guys for all the work you're doing, and just kudos to anybody who's listening, because they're putting themselves first. And as parents, that's so important to just be able to do the things that we need to do for our body so we can get back and do what we love to do.
Yep. All right. Well, thank you guys. I know we had like 360 people registered, so a lot of people are probably watching later. But thank you again, and we will talk to you guys another time.
Yeah.
Thanks
Bye,
for
guys.
being here, everybody.
Bye.